This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
My name is Taylor, and today we're going to talk about the anticholinergic toxidrome. The anticholinergics are found in over 620 compounds, including over-the-counter meds, prescriptions, and plants. Today we will talk about the patient who has taken an anticholinergic medication in a supratherapeutic dose and who will present with a very specific pattern in your emergency department that you must recognize. We're going to delve a little deeper into the specific types, mechanism, presentation, treatment, and finally disposition of a patient that has overdosed on anticholinergics. So what are the different types of anticholinergic medications that we see on a daily basis? Number one is antihistamines, such as diphenhydramine or Benadryl. This is the most common anticholinergic toxicity seen. Number two is tricyclic antidepressants, such as amitriptyline. Number three is atropine. This is used for bradycardia and also to treat organophosphate poisonings, which is a cholinergic toxidrome. Number four is antipsychotics, such as olanzapine. Number five is Antispasmodics, such as dicyclomine or oxybutynin. Number six is Jimsonweed. And finally, number seven is Muscaria mushrooms. So what is the mechanism of these drugs leading to this toxidrome? Anticholinergic drugs competitively inhibit the binding of the neurotransmitter acetylcholine to muscarinic acetylcholine receptors. Keep in mind that the diagnosis of an anticholinergic toxidrome is largely clinical, and therefore your history and exam will be crucial to an accurate diagnosis. Lab values and tox screenings will not be helpful in the diagnosis. So how does a patient present with these symptoms? Well, here is where the Alice in Wonderland reference comes into play. Number one is dry as a bone. This is anhidrosis. Sweat glands are innervated by muscarinic receptors, so anticholinergic medications produce dry skin. Keep in mind that a cocaine toxicity presents very similar to an anticholinergic toxicity, except that a cocaine toxicity will present with moist, diaphoretic skin. Number two is red as a beet. This is a cutaneous vasodilation that occurs as a means to dissipate heat by shunting blood to the skin in order to compensate for the loss of sweat production. Number three is hot as a hare. This is an anhidrotic hyperthermia. The interference with normal heat dissipation mechanisms, i.e. sweating, frequently leads to hyperthermia. Number four is blind as a bat. This is the non-reactive mydriasis. Muscarinic input contributes to both pupillary constriction and effective accommodation. Anticholinergic medications generally produce pupillary dilation and ineffective accommodation that frequently manifests as blurry vision, especially for near vision. Last is mad as a hatter. This may present as anxiety, agitation, dysarthria, confusion, disorientation, delirium, psychosis, coma, and seizures. It can also present with hallucinations, which are often described as people picking or grasping at inanimate objects. So, this patient comes into your ER. What do you do? If there's ever any uncertainty on what to do, contacting poison control should always be one of your first steps in any toxidrome to help decide the treatment path you're going to go down. First and foremost, though, always start with your ABCs. That's airway, breathing, and circulation. Next is benzodiazepines. This is used for both supportive care and for agitation and seizures. Lorazepam 2 to 4 milligrams IV or 0.1 milligrams per kilogram is the typical dose. Next is sodium bicarbonate. This is only used with TCAs when they cause a widened QRS complex. If untreated, there's a risk for profound bradycardia, torsades, and seizures in patients with widened QRS complexes, so you must get an EKG and treat right away. Number four is activated charcoal. This may be used only if the patient presents to the ED less than 1 hour post-ingestion. Number five is temperature monitoring. This is crucial treatment as these patients will often be very hyperthermic and may need active or passive cooling measures. Finally, let's talk about the controversial physostigmine. This is an acetylcholinesterase inhibitor. The controversy comes from reports of asystole and seizure that resulted in a black box warning. Vasostigmine is contraindicated in TCA overdoses. It is able to cross the blood-brain barrier, thus it is useful in reversing the peripheral and the central effects of an anticholinergic toxicity. No randomized controlled trials have ever been conducted in humans demonstrating the efficacy of vasostigmine. The cases where FISO is indicated are those in which you are absolutely sure this is an anticholinergic toxicity and the patient has delirium. So you've treated your patient in the ED. What do we do now? Let's talk about the disposition of your patient. The admission criteria for a patient with either a confirmed or suspected anticholinergic toxidrome is as follows. Symptoms lasting more than 6 hours, CNS findings, QRS prolongation, hyperthermia, and rhabdomyolysis. However, if they have delirium, dysrhythmias, seizures, or coma, or patients that require repeated vasostigmine treatment or a vasostigmine drip, they need to come into the ICU. If the patient has none of these symptoms, they can be sent home after an observation period in the ER. Keep in mind that gut motility is slowed in anticholinergic patients, and thus toxicity can be prolonged. Do not let this fool you into sending your patient home prematurely. All right, guys, let's do a quick recap. Anticholinergics are found in 620 compounds, with the most common being Benadryl, TCAs, antipsychotics, and Muscaria mushrooms. The patient will present with the Alice in Wonderland analogy of dry as a bone, red as a beet, hot as a hare, blind as a bat, and mad as a hatter. Treatment is largely supportive with benzos for seizures and agitation, and possibly vasostigmine if you're absolutely sure this is an anticholinergic toxicity and they've got delirium. Sodium bicarb may be used for prolonged QRS. Remember to always call poison control, as they're a phenomenal resource for any toxidrome. Thanks, guys.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.